So, Jason, thank you. I'm not sure if you're here because you have an interest in technology, an interest in healthcare, or you just enjoy pizza. Nonetheless, I'm glad you're here. So just a little bit about me, which will maybe kind of inform what we're going to talk about today. As Jason said, I am a pharmacist by practice. I practice in a clinical setting for many, many years. And my role has shifted. And so what I've decided to do is to impact pharmacy and patient care delivery at a larger scale. And I'm using technology to do that. And so working with Premier, I have the opportunity to help inform, build, design, and product roadmap and manage solutions that impact direct patient care. And one of the opportunities I have is to work with a lot of really smart people. But a lot of those really smart people have actually never worked in a hospital. They've never even been in a hospital in some cases beyond the day they were born. And so one of the things that we do before we do a big project is that we get Craig time. And Craig time is me putting them in the shoes of either a patient or a clinician. And so if you would, embellish me just for a moment. I'm going to put you in those very same shoes in just a moment. What I want to do to kind of focus our time together, hopefully it'll be somewhat interactive, but we're going to journey through kind of what the evolution of healthcare IT is. Healthcare technology is not on the same trajectory that I think other aspects of whether it's in finances or personal technology that we use, but it has come a long way. So I'm going to walk you through that. I'm going to walk you through some of the challenges that clinicians still face as they're trying to take care of patients on a day-to-day basis, and really hopefully help you identify maybe what clinicians need to identify patients at risk. Because the concept is that, you know, at some level when you're in a hospital you're sick, right? But they're sick and then they're getting worse, right? And the question is, if you've ever had a family member, if you've been a patient in the hospital, you're kind of by yourself a lot, right? You know, when you're in a hospital, maybe not enough when they come in at 3 a.m. and kind of draw labs, but beyond that, you're kind of on your own until the doctor or the nurse comes by. And so the question is, who knows when your risk level's going up, and how would anyone know that, right? And so we're going to talk a little bit about what clinicians need to identify those patients that are deteriorating. And then I'm going to talk just a little bit at the end about how we're trying to solve this challenge. So again, if you don't mind, let me kind of, I'm not sure if you're walking out of meetings, you're walking out of another tech talk where you had lunch there and now you're having it here. I don't know what you've been doing, but let me try and orient us all to kind of think a little bit differently about the problem. So one of the interesting things is Cleveland Clinic made this, but who did they make it for? Yeah, the workers, the employees, right? Because one of the major reasons is that patient care delivery is hard. Delivering good patient care is a hard thing to do. And so, again, we all have emotions, patients have emotions, family members have emotions, and I can tell you there is a symphony of things that are occurring anytime you walk into a hospital or a healthcare system. Why do you think I show this to my development team?
So they can see past the numbers.
Absolutely. We work with a lot of code, we work with a lot of data, we work with a ton of validation tests, right? Because people are going to use our stuff to take care of maybe your family members. And so I have to remind them that behind the numbers, there's actually lives here, right? And for us to be sensitive in the way that we think about data, for the way that we think about technology, for the way that we think about developing things and developing technology that clinicians are going to use to actually deliver care. So what I want to do is kind of tell you where technology was in healthcare and give you a preview of and better understanding of where it is today. So back in my day, so I practiced for over 10 years in critical care medicine, and as I shared with someone, I worked in trauma critical care, which meant that I got up at 5 a.m. every morning. I would turn on the news, I'd turn on the television, because guess what? I would start learning about my patients. Who got robbed, who got stabbed, who was in a car accident, who got shot, and I would start learning about the patients that I was going to go see in about an hour, hour and a half. And then I would arrive at the hospital, and guess what I did? Because I'm old, I would have to go gather a bunch of pieces of paper. I spent most of 5:45 to 6:30 gathering pieces of paper with words and numbers on them so that I could get a picture of the patients that I was about to take care of. Because the problem, the challenge I had when I walked in the hospital was that I had 20 patients on my critical care service. I had 40 patients on my floor service that were less critical. Who did I see first? Who had the challenges? Who was sick? Who was getting worse? How do you even know that, right? And so I would collect data to try and find that out. I would have conversations. But guess what? There's one of me, there were like 70 of them, right? And so it was very hard to do that at scale. So back in my day, when I was practicing, patient care required that you actually had to be there. Heck, you can be anywhere now, right? If you have access to using technology. It meant collecting data, it meant filling up paper, filling out forms, data collection forms. I was the king of data collection forms. There was nobody in my department who could build a better form than me, right? But that form was paper, and you had to have a pen or pencil. And then patient care meant rinse and repeat, one patient at a time, right? I had to log in, grab some data, write on a piece of paper, go pick up some lab sheets off of a printer, and I'm trying to collect puzzle pieces to understand who the patients are in front of me and which ones need my attention, which ones need prioritization. So that's at the individual patient level. But back in my day, when I tried to understand, were we delivering good care? Were we using the right drugs? Big data meant going to medical records and seeing a bunch of charts and a bunch of pieces of paper. It meant analytics mean going to medical records for days, and benchmarking occurred when medical residents that were doing their research projects would fall asleep and their pen would mark the bench for the chairs they're sitting on. That was benchmarking back in the day. And so one of the challenges that healthcare has faced is that it is more slowly adopted, the digital revolution that I think we experience in so many other aspects of our life. Now, the good news is that there was something called EHRs, EMRs, electronic healthcare records, or electronic medical records. They're really synonymous. People use both. And if you go out and you use Google or whatever your search engine of choice is, if you Google and you go put in EMRs, you're going to get the most glorious things, right? You're going to get the most glorious photographs of people that are just happy engaging with that technology. And I will tell you that EHRs are critically important because, again, back when I practiced, when I was very young, at the beginning of when I practiced, we would actually have to handwrite the medication orders, right? And keep a log of what patients were on. Well, EHRs are critically important because they become a repository of data where now I can go to one place, access from any number of places within the hospital, and maybe even outside the hospital, and actually find out what's going on with the patient. I can look at their meds, I can look at their labs, I can look at their past medical history, I can look at their vital signs. I now have access to patient information in a way that I've never had before. And so one of the things that EHRs have become is a destination for you to put documentation, which is critically important. You have fewer storage issues, you don't have big file rooms, you have computers, right? And so they also streamline patient care process. They give you a vehicle, a medium to say, you know what, we do 4 acute MIs every day, 4 heart attacks a day. There should be very little of variation in the care that we deliver. We can standardize that and use an electronic medical record to do that. But the reality is that if you go out and look at interviews with CIOs for healthcare systems, what they will tell you is that they've taken EHRs that have really moved care forward in a lot of ways, and they've contaminated them. They've contaminated them to be a place to document process and to meet a regulatory requirement that allows them to get paid. And so what they will tell you is that it's not elegant user design, it's not user-centric design, it's not even helping you dig through all of that data that's there to help you bubble up the most important information. And despite the folks that are so happy to use this, which I've never seen an iMac in a hospital in my life, despite the fact that this guy is so giddy, I'm not sure if he's looking at a lab result or a culture or what, or I'm not sure if this is the tablet they give you at Verizon free, but whatever it is, you know, the EHRs are not the panacea at which they've predicted themselves to be. So EHRs have moved us forward in terms of technology, but they're still lacking in a number of ways. In fact, they even promise this. This is an actual picture of when you like go out and you're looking for images around EHRs. This comes up. This is like Minority Report. Like, I mean, it's like you can just move stuff around and suddenly you have all the information and patients get better and you've just ordered your pizza. Like all at the same time, right? So there's a different reality going on. And what do you guys see here? Paper, right? What else do you see?
None of them are as happy as your last picture.
That's exactly right. So it's not a panacea. I see pens, I see papers everywhere, I see paper folders, I see paper forms on a clipboard. I see 5 clinicians and only one of them is actually standing in front of a computer. The rest either have a pen or paper in front of them. So there's still a need that's not being met in a lot of ways. So one of the challenges in this technology age where we have these wonderful EHRs is that we're now beginning to deliver EHR-centered care versus patient-centered care. And so when you look at a number of studies, one of them found that interns spend about 12% of their time in direct patient care and 40% of their time actually engaging with the computer. They spent more time digging up the data than actually spending time with the actual patient. Another study reported that, again, their actual concern is they spent more time in activities only directly or indirectly related to patient care, like reading charts, writing notes, entering orders, speaking with other team members, and they only spend about 8 minutes of their day with an individual patient. And so EHRs have solved a ton of problems, and don't mishear me on that. They've also created a number of other problems as well. So as a clinician, as a former clinician, I still think I'm a clinician, by the way. As a former clinician, you know, there are challenges that you face in actually delivering care. One is that you got to find the needle in the haystack, right? You got to find the actual patient who's getting worse and getting worse right now. You got to identify that the patient who is on like 3 antibiotics, and guess what? They were on an antidepressant that they're not on in the hospital, but because the half-life, because it's still in their body, they're actually going to have serotonin syndrome, have a seizure, and die. You got to find those needles in the haystack, right? You got to identify that the patients that are on have a new positive culture, their blood pressure is dropping, their urine output's dropping, because guess what? You not only do you have bacteremia, bacteria in your blood, you now have clinical signs of sepsis, right? And you've got to identify that patient at a time. So EHRs are not equipped to do that, right? So clinicians need automated surveillance. They need to find the needles in the haystack. So I'm going to ask for a volunteer. And you look like a good volunteer.
I think I'm a good volunteer.
So David,
Yes.
you are, let's face the
We'll go
group here.
here.
You're a pharmacist.
I've been for years.
You're a really good one.
Yeah, but I'm very tired.
Me too.
It's
So
the industry.
you look out, this is your hospital. This is your population. And you have 2 patients out here that are getting worse. Who are they?
Well, if I pick and I insult them, that's just mean.
Pick.
There's no way to tell
And why is that?
because there's no data.
You don't have the data. And so unfortunately 2 of you had an infection, you were getting worse, you were not discovered in time, and you're no longer here. So
Sorry, guys, we'll miss you.
absolutely. And to find out who you are, you may want to look underneath your chair, because you have something to identify yourself as the sick individual who is no longer with us. And if you have it, hold it up. If you have it, hold it up.
You made it.
Yeah. Guess what? You're dead, so you get a Starbucks card. Absolutely. And you get one for playing. Thank you. You died. Hey, I've never seen somebody so happy to die. I'm died and I'm going to Starbucks. Yeah, it's like a great thing. So as a clinician, you're looking to find the needle in the haystack, right? You need to identify the patients who are at risk based on a number of factors, not just because of a drug, but in light of a drug, a vital sign, a white blood cell count, a serum creatinine, a number of clinical lab factors. Putting the picture together is not easy to do, right? You also need data. So once I've found you as a patient, there's some things I need to know to determine what action I need to take. I need that data to determine what that next action is. I also need a place to capture what I did, because I'm about to make a decision that's going to change your therapy, that's going to change your care plan. I probably want to capture that somewhere. And what I want to do is that I want to be able to look across this population over a period of time and figure out what I can do better. What is it about the care? What is it about the care that I'm delivering that can improve? Am I using the right drugs? Am I ordering the right labs at the right time? Am I giving the drugs at the right dose? And so there are analytics that would absolutely inform it and maybe dictate how I might care for you next time you come to my hospital. So as a clinician, when I need to face the challenges of discovering who those sick patients are, to help prioritize, all the things I have to do and make sure it's focused on the right people, I need to find the right patients. I need the context, the clinical data to understand what I need to do. I need to capture what I did, and then I need the aggregated insights to inform how I do things going forward. And these are the challenges that clinicians are facing, and those are the things that they need. So unfortunately, as I've already kind of shared, EHRs are not meeting that clinical, what I call clinical decision support need. They have all of the clinical data, but it's data. It's not information. It's not necessarily informing clinicians as to who those priority patients are. And so there are a couple of reports, and one from a hospital that I've been at that was very well known and very well in the news when in the Dallas, Texas area, when a patient with Ebola was in the hospital, it went unrecognized. And even when it was recognized, that patient wasn't isolated quickly enough, and other patients and healthcare workers were also contaminated, right? And one of the concerns was highlighted in blue, just for you, inability of the EMR to reconfigure rapidly in response to a public health threat, right? It is a very structured place to put data in and to pull pieces of data out. It is not a place to go to look across and find intelligence to help you deliver better care. Another study noted that clinical data for action is often obscured in the EMR. It is so buried, right? It is so buried that sometimes, even though the data is there, it's actually hard to use to take care of patients. So I think there are really three things that hospitals are looking for, specifically clinicians. One is they're looking for data. They're looking for data in real time. They need actionable information that they can act on. Not only to use to find patients, but also once they find them, to have the information available to make the best decision. The other is that they need clinical surveillance. They need automated detection of those patients at risk based on complex algorithms and rules. It shouldn't be because I'm having to put the puzzle together and then deciding, so what does this actually mean, right? Again, there are well-known triggers, there are well-known things that would indicate whether you as a patient or a family member are getting better or worse. Why are we not trolling through the data to illuminate those insights and telling somebody about it, right? And then the third thing is a partner. And so I work at Premier, and we view ourselves as a partner. We are a publicly traded company, but you may not know that we're actually owned by 200 health systems. So those 200 health systems dictate and inform how we deliver our products and services. And so we do that in a number of ways. We advocate for them in Washington, D.C. on healthcare policy. We provide consulting to help them understand how they can either remove costs or improve delivery of care. We also provide them IT solutions. But the interesting thing is that we don't view them in a vendor-customer relationship. In fact, that word, don't use it if you come in my building. You have to use the word member, because they are part of a healthcare alliance where we at Premier are partnering with them. And so Jesse, who's a clinical product manager at the rear of the room, who works with one of our products, we go out and we engage with our members because we need to better understand what they need in our products, tools, and services so that, again, they can deliver better care. Now, we've been heavy on the healthcare, short on the technology. So if you're technology, we're about to move in that space. But this is how we're actually solving the problem of giving clinicians data, giving them automated surveillance, and then giving them results that actually matter. And so we have a product that's used in over 1,200 hospitals called Airdock. And it's helping clinicians find patients, it's helping them assess patients, and it's also helping them take action to improve the care. And the results kind of speak for themselves. We're helping hospitals save money. We're helping hospitals more efficiently identify infections. We're also helping them reduce unnecessary antibiotic use, which is a topic in the news today. We're also helping them reduce cost as well and length of stay. So how do we do that? How do we leapfrog some of the challenges we've already talked about? One is that we're actually when we engage with a hospital, what we do is, as a part of our implementation, we're actually setting up interfaces for transactional data. We want the data as soon as it's available. Sometimes it's from an EMR, sometimes it's from an ED system, sometimes it's from a surgery system. Dirty little secret, when you go in a hospital, they're going to tell you they have an EMR and it has all the data. It ain't true. It ain't true. That's a southern term for some of you. So, and the reason is that they have a primary system, right? But they have all these ancillary systems, right? And so sometimes Airdock is the only way that you can actually see all that data together in one single system because it's not all in the EMR. And what we do for different types of data, patient data, lab data, pharmacy data, surgery data, vital sign data, imaging data. We get all that data as a transactional feed, and then we integrate that. We actually have a pipe. We pull it in a secured manner. We process through that data. We normalize that data, and we'll talk about why we do that in just a second. Then we can actually, we have our alerts engine that's actually applying the clinical rules at the transactional level. So we don't apply these rules like at night and then send you an alert in the morning. As the data comes in, our rules are running against that transactional data, and so that we can notify clinicians as things are happening. And really, we're taking this data in, we're applying our rules for a number of reasons. One is against surveillance. We are known in our industry as a trusted source for surveillance. Surveillance not in the NSA way, but surveillance in the good way, right? Because if you're in the hospital, you're sick, you want to be discovered if things are going wrong, you want surveillance, right? And so we're known because we have, you know, a number of assets, and I'll talk about that in a minute, in ways that we can actually discover sick patients. We also provide our analytics. The other thing is that we use this data to help them meet regulatory reporting, which is not a voluntary thing, but it's something that hospitals are having to comply with. So that's the data itself. It's getting it fast, getting it often, getting it normalized, and so that you can use that data in a number of ways. Now we talked about the haystack, right? We talked about the patient problem, right? I'm a clinician coming into a hospital, like, who are my priority patients I need to see, right? There's 70 of you. Who am I going to see first, right? We talked about that. But let me give it to you from a data perspective, because that needle is really small in that very big haystack. And what I mean is that today at over 1,200 hospitals, we're going to process 71 billion transactions across our fleet of hospitals. When you look at it from a hospital perspective, a single hospital, me as a clinician looking at all of you and trying to figure out what's going on, I'm having to, if I were to look at every transaction, I'm having to look at 60,000 transactions. Now, I'm going to tell you, Jesse may not agree, I was good at what I did. I was never that good, right? And so that's the average number of transactions coming in for an average size, 400-bed hospital. Let's look at it from a patient perspective. If I'm going to come take care of Jason because he may have an issue, he's going to create at least 133 digital transactions in the course of a single day, right? That is a lot of data a single patient generates. And so the haystack is big. And so even if you think you're good, and even if you think you've been doing this for years, what EMRs have done is created transactional digital data that can be used and consumed, although they haven't provided the best tools to do it. The data is there. The challenge is how do you actually engage with that data to find the meaningful insights, to find the at-risk patients. Now, so that's just the data we process, right? So I talked about this idea of normalizing the data. So that is a process that we do when we set up a hospital on our product. It's also an ongoing process. And this is just a visualization of one of the things that we have to do. So at your hospital, you give drugs, right? And so they're going to be ordering drugs. Patients are going to be on drugs. Well, we actually have to map that to something, right? So that we know that cefazolin 1 gram, cefazolin 2 grams, cefazolin 2-gram injectable, cefazolin, frozen injectable bag. We know that all those things are cefazolin, right? The data is so gnarly and nasty. What has to happen to make this stuff actionable is you have to normalize this transactional data till it's meaningful. So this is the series of relationships for our drug standards. And so this was actually put together because Jesse and I, bugged our analysts so much about, hey, what's the hierarchy here? How are we handling certain things? Hey, there's a bag right behind you. Can you bring that to me? I appreciate that. Yeah, he got so tired of giving us Excel spreadsheets, he decided to innovate. And so now we can go search for drugs, and we can understand how drugs are being mapped. Is it?
Yeah, it's in your bag, I think.
Fantastic. We'll go fast for Q&A. You guys are like, great. So one of the things that we do, once we process all that data, and we do so on an ongoing basis, once we've normalized the data, these are the front-end tools that, again, EHRs just don't have. We're giving clinicians the ability to act. We give them over 500 alerts, right? And if you can't find something in there you need, or there's something missing, we give you your ability to build your own. We also give your ability not only to be interrupted, because that's what an alert is, right? We give the ability for a clinician to say, you know what, when this happens in my hospital, when a patient's on this drug, with this lab, with this diagnosis, somebody tell me, right? We give, I want to be interrupted as a clinician, that's what an alert is. Interrupt me so that I can turn my attention and see if I need to take action. We also give you an ability to look across the entire hospital and say, hey, who's on this drug, who's had this surgery, who has this lab value, who has this infection, and look across your health system. Not with an IT ticket that you have to send through Outlook to go to your IT, hospital IT staff, and then you get a report a week later. You get front-end tools to know now, because you can have actionable lists to see who I need to maybe evaluate, to maybe have a change in therapy. So we give them a number of tools for surveillance. We give them a number of tools to actually understand the experience of healthcare. So Premier is actually known for a lot of healthcare analytics, but our contribution to that, our contribution to Premier, is our analytics on real-time data, because that analytics on real-time data is very different than big data analytics. And what we do is we not only meet some of their individual reporting needs, but we aggregate data up so they can look across not just their hospital, but they can look across their 160 hospital system. Now that's important to a number of our health systems, or 35 hospital systems spread across 8 states, right? Where care can be delivered a little bit differently, and they're trying to figure out how to standardize care, right? And so looking at a hospital and then looking at an enterprise, but then also taking it all the way down to an individual unit level, because even inside of a hospital, patients and patient care delivery can be very, very different. And so again, this is how at least we're trying to meet the challenge that clinicians have. And then finally is a new product offering that we have is Clinical Assistant. Our product's been around for a number of years, and so it's fantastic. It has all the bells and whistles you could ever want. It is lacking, and one of the ways it was lacking was that you had to be in front of something to use it. And so partnering with Skookum, they helped us develop a mobile design that was engaging, that allowed us to engage not only our existing users, but also other types of healthcare users within the hospital. And what they've been able to do for us is actually help us through an iterative design process to really deliver value to our hospitals, so that at the point of care, they can have the information they need to take care of a patient. When they're in the cafeteria, when they're on the way to the parking deck, they can be interrupted with that latest alert. They don't have to be in front of a computer. The other little dirty secret is that care always happens at the bedside. No, it doesn't. In the hallway, in the bathroom, in the cath lab, in the cafeteria, and some other places I won't even tell you about. Care happens everywhere, right? And so your ability to know and to know now is critically important to that patient who's deteriorating. And so Clinical Assistant gives our clinicians that ability to know now what's going on, and have their day interrupted to take care of that patient priority, and then also have the necessary clinical data that they need to make a decision. So I'm going to close with this, and we can finish up with questions and comments. So how do you identify patients between the zeros and ones? The first thing you need to do is remember that they're human. They're patients, right? And that's one of the fringe benefits of doing what I do and traveling around the country and engaging with our over 1,200 hospitals. I get to walk in the hospital and be reminded of what it means to deliver patient care. The good news is that I don't have to fill out paperwork and do a bunch of other administrative stuff I used to do, and I hop on a plane and come back to Charlotte. But the important thing is that we have to remember that the zeros and ones are patients themselves. And so how do you do this? How do you identify at-risk patients? You capture the clinical data in real time. The data tomorrow doesn't help me. The data now does. You have to normalize that data because healthcare data, sometimes it's discrete, sometimes it's not discrete. Sometimes it's highly structured, sometimes it's not. And sometimes it's highly varied in terms of what things are called in a hospital. That doesn't seem logical to some of your engineering minds, and I'm going to tell you, yes, it's not logical, but it is reality. And so that has to be normalized so that we can have consistent alerting and consistent reporting. The other piece here is that having the data is critically important, right? Having it normalized is critically important, but actually having a rules engine in an automated fashion, looking for the clinical triggers that are in my brain, but if my brain's not in front of the data, then how's it helping the patient upstairs, right? An automated process that can signal clinicians that there's something that need to be addressed, and to notify, or as I like to use the word, interrupt them in the course of their day through automated detection so that they can put that data into action. And then finally, deliver the patient opportunities to clinicians in a user-centric approach. If I was honest, we did not have a user-centric approach to our product. Our product had a lot of capabilities. It leapfrogged a number of the challenges we've already talked about, but it wasn't a user-centric approach where we were putting the best information at the right time in front of the clinician to help them get to the best decision easier. And through our mobile design with Skookum and now other engagements, that's beginning to happen. And so with that, I'll take any questions or answer anything you may have. Just on time. Questions, thoughts, comments?
Yes. So 2 questions kind of combined into one. Is Airdock in essence a data warehouse, and with some sort of intelligence layer on top to deliver analytics and stuff? And then the second question is, if it is a data warehouse, have you looked at solutions like a data lake or a Hadoop type platform that are really targeting really vast amounts of data?
Yeah. So she used Hadoop because I use clinical terms, right? So, so what I would tell you is that Airdock does not, the product offering or the Oracle database behind it, we don't consider that to be a data warehouse.
Okay.
It is fully rich of data, and it is fully rich of data that we are going to look through, comb insights, and then deliver back to our users, but we don't actually consider it a data warehouse. Premier itself does have an enterprise data warehouse, and some of our data does contribute itself to it, but within our point solution, we don't consider it to be a data warehouse.
Okay.
Now, in the enterprise data warehouse, they are using a number of technologies. Hadoop is one to aggregate, to comb through the insights and the relational insights around that data. So, you're welcome. Yes, ma'am.
My question was kind of more about the patient side. How is what Premier does and the EMRs, how are you guys gearing it to help the patient know what medication they're on, advocate for themselves, understand what interactions could happen?
Yeah, so that's a fantastic question because you're hitting on a direction where we're headed. So we've been on this journey of really kind of informing medication management and patient care delivery within the walls of the hospital. That's really what we're known for. It's what we do and do very, very well. 1,200 hospitals kind of says that, right? 1 in 5 hospitals. But we haven't really addressed that outpatient problem, right? Because one of the things that we've seen as a challenge is that you've now, as a patient, just had an episode where you were so sick that you needed, daily care inside of a hospital, and then now you're going to be discharged, and you know that on average, 31% of prescriptions provided at discharge are never filled. Do you know that 30 days, within 30 days of the readmissions related to drug-related problems is over 60%. 60%, because we're not focused on the transition of care from the inpatient to the outpatient, and we're not focused on the patient for a period of time, those high-risk patients, once they leave the hospital. So our solution doesn't do that today. Jason's probably smiling because that's something we've already talked about. We're positioning ourselves for, and why? Because we take a member-driven approach. Our health systems are struggling with this. Do you know that if you're discharged from the hospital and you're readmitted back to any other hospital, do you know that if you're readmitted within 30 days, that original hospital has to pay for the total cost of care for that second admission. Hospitals are on average, have like a 3 to 4% margin. Do they want to cover that readmission cost? No. And so whether you prefer a carrot or whether you need a stick, right? The government's giving a stick in this case, and they're giving the stick to the healthcare system and saying, you know, you're going to be on the hook for low quality care. And so health systems don't want to absorb that. Health systems see that as a financial risk, and then a risk to their brand, right? Honestly, if they have a high readmission rate. And so we want to help engage with solving that next form of problem as patients leave the inpatient setting to the out, and then for those high-risk patients for an ongoing period of time. Yes, sir.
Kind of looking at your picture earlier that you showed of 5 doctors and only one of them was at a computer. How successful can you be at getting a hospital to really get the full potential out of Airdock? I mean, is there hiccups, I would assume, that come along with, all right, we've got to be able to utilize this, and everybody's got to stay on point with it?
Yeah, so what I would tell you is that you don't implement at 1,200 hospitals without learning a few things. And not having a few regrets you'd like to turn into lessons learned to avoid next time. And so what I would tell you is that what we do, and I think this is true for healthcare in general, is that healthcare as a technology just fails. It just does. And so service-enabled technology actually wins. And so what we've done and redesigned is, when we implement the technology solution, we have over 20 clinicians that are part of our organization. So I have 150 people working in the clinical surveillance business at Premier on different parts of building stuff, testing stuff, supporting stuff, training members on our stuff. We have a lot of stuff people, right? And so what we've learned is that when you implement the technology solution, we have to wrap our clinicians around the clinicians that are ultimately going to be using the software once the implementation is done. So we have a very high-touch model where we have a pharmacist and infection preventionist, our 2 core users at a hospital. We have those representatives working with hospitals during the implementation to understand what are your goals, how do you work, how are you organized, geographically across the hospital, so that when they come into Airdock and they come to a point of training, it's meaningful. We have all their alerts ready, we have their lists ready, we have their reports ready, everything that they need. And so I think so we have a high-touch model that increases our adoption and kind of addresses some of the challenges. The other part, which is one of the reasons why I'm in this building on this floor today, is really improving our user design. And so we have a real opportunity to lower the bar for a naive user of our product to use our product successfully. So that's really kind of the next phase.
Speaking of user design, I work at the hospital, it seems to me. I have a lot of nurse friends that say that they're inundated with a lot of, logging into the computer, putting patient information. I think you spoke about that, how doctors spend more time looking at the computer than talking to the patient.
Yes.
How does your product kind of approach that in terms of, telehealth, maybe a doctor voice animated where they can speak and have another doctor kind of chime in, that sort of thing?
So there are a number of virtual centers and healthcare delivery technologies that are available. Premier hasn't engaged at that level. We have not traditionally seen ourselves in the provider space. Not that we haven't dipped our toe there, but we are more of that service-enabled technology provider where we're going to partner with you as an organization to be successful. We haven't really kind of gone down the path of using us as a remote center, right, for a virtual technology to kind of inform the decisions being made around a patient's care. So, the lucky person.
Perfect. What challenges has Premier faced in your innovation as a result of HIPAA and data privacy, and how do you navigate those?
Well, one is that I have to do a 2-hour course like every year. So let's just name it. So it absolutely informs what we do and how we do it. And so I'll give you an example, a tangible example. So with our product, we can have our product on premise in their data warehouse, or we have a cloud solution as well. It's really up to them. A number of factors go into why one chooses one versus the other. Regardless, there is a high level of credentialing and how we support and who gets to log in and see that data. For those hospitals that are in the cloud, there's a lot of data security and encryption standards that I'm not going to speak to around the transfer of that data to our data warehouse and the accessibility of that information. So it absolutely informs everything that we do around patient data. So, yes, sir.
You mentioned in the old days it was retrospective analysis, and now we're doing real-time analysis, which I know is really hard. Is there any lean towards predictive analysis in the hospital instead of saying these things have happened and now it's already happened, we need to catch it before that guy walks out the door, to these conditions exist, so something's about to happen?
Absolutely. So there is a major meeting called HIMSS. I'm not sure. It's one of the largest healthcare IT meetings, and so you can always tell what the prevailing theme is because it's on everybody's booth, right? And so predictive analytics is everywhere at HIMSS, right? Because it's what people are talking about. It's what we know is like the next level, right? Not only just knowing what's happened in the past and doing better next time, versus, hey, let's do better right now, to, hey, let's do better, let's use those insights to avoid some problems and deliver better care. That's on everybody's mind. I'll tell you, a number of people have a variety of technology approaches that they talk about. What most people don't have is a data source. And so the data is the limiting factor, I think, right now for predictive analytics, partially because of what we just talked about, because who owns the information that you're going to use for that predictive analytics? And generally, it's accepted as it's under the authority and the responsibility of the hospital to protect that data. It's our responsibility to protect it as a vendor. And so we don't get to use the data without the hospital's permission. And so there are things that are happening now, even at Premier, for us to begin to marry the appropriate data sets, right? Because what do you need for predictive analytics? You need to know what the descriptive data is, and you also need to know what the outcome is. Well, guess what Airdock has? I can tell you when they were admitted, I can tell you what drugs they were on, I can tell you what drugs were administered, at what dose and route, I can tell you all the vital signs and the lab results, when it was collected versus when it was I can give you all that, right? But what actually happened to the patient? Airdock doesn't have that. Other assets at Premier does. So I think there's a couple of things to get to that predictive analytics panacea that everyone at HIMSS talked about. One is that you have to arrive at the data set of descriptive data with results. And then you're going to have to do a lot of testing of models to arrive at what that is.
All right, guys, can we give them a round of applause real quick?